Good morning. We are going to go live on Instagram. Okay. Hi, everyone. Good morning. There's actually some sunshine, which is lovely. I wanted to, in light of my Not Your Mom's HRT being tomorrow, we still have a few spots left for in person. And if you can't attend, even if you can't attend live and you want the replay, you can sign up and you can register for virtual and you will get the replay. Everyone who attends will get the replay sent to them after the session. So even if you can't make it, come see the live session. So, Not Your Mom's HRT. Basically, what we're going to do is we're going to talk about hormone replacement therapy in a way that you've probably never spoken about it or heard about it before. But today's live, I wanted to talk about bioidentical hormones, bioidentical versus synthetic, and what is better, because this is a small portion of what we are talking about during our Not Your Mom's HRT session, with the goals of having you come and feel really confident about whether or not you should be taking HRT, whether you should consider it, whether you should talk to your doctor about it. I want you to feel really good about the information out there because I think a lot of it is really confusing. And so that's kind of why I've done this session. So, again, if you want to register, I'll just put the link, laurapiper.com/events, if you want to register for the session. It's tomorrow. But today, live, we're going to talk about specifically bioidentical versus synthetic hormones and why you might choose one over another, and just kind of going through the information that we see online about bioidentical being better, bioidentical being safer, the creams and the patches, and what's the difference. So let's just go back a little bit. When we are choosing hormone replacement therapy as an option, as a treatment option, we have to look at a few things. Kind of the rules of engagement here are that we have to give, if you have a uterus, we have to protect the uterus, because one of the major risks of hormone replacement therapy is that when we give estrogen unopposed, we run the risk of the uterus growing a lining that's too thick. So, one of the risks that we are treating against is that thickening of the uterine lining. And so, how we treat against that is by giving progesterone. So, if someone has a uterus, the rule of thumb is that we give progesterone and estrogen. Okay. And so the way we deliver and the way we select those hormones has to do with a number of factors. A lot of people get really caught up in, I really want bioidentical, I don't want synthetic. And so let's talk through that. When we look at the delivering of hormones, when we look at just bioidentical, so what is bioidentical? This is basically body identical. These hormones are as similar to your natural hormones. Now, what a lot of people don't know is that your bioidentical or body identical, structurally similar to the human hormones, are actually derived from plants, but they can be in two forms. So your bioidentical hormones can actually be found compounded and can be found in pharmaceutical preparations. I say that because a lot of people are freaked out when they see a prescription or something they can get at a pharmacy. They assume it's synthetic, it's worse, and that sorry, I have something stuck to my lip chat. And that we should be going with something that's bioidentical, that is compounded by a independent pharmacy. Now, when we look at kind of the bioidentical landscape, I look at compounded and pharmaceutical bioidenticals as different entities, right? When we have something that's compounded, where you're going to a pharmacy and they're actually creating that prescription for you on the spot, there is the risk of human error with dosing. There is the risk of contamination. We do find that dosing is inconsistent. And there's a lack of clinical trials in those compounded prescriptions. And so when we have a bioidentical compounded prescription, in my opinion, we should only be using that type of prescription if for some reason a patient cannot tolerate the dosages available over the counter. Also, and I've mentioned this in other conversations and other live videos, it's a lot more expensive to get a prescription compounded just for your unique needs. And so, from a cost perspective, when we look at the duration that someone's going to be on hormone replacement therapy, we're going to go into the duration and talk about the duration a lot more. But when it comes to the duration, someone's going to be on hormone replacement therapy, like you could be on it for 5 years, 8 years, 10 years, right? And so we have to look at that cost long term. It's not like a supplement where we're saying we're going to take it for the next 3 months and then we're going to like reevaluate, right? When you're on HRT, we're saying, okay, this is our treatment plan kind of for the long haul. And so we have to look at cost. And so usually a compounded prescription is going to be more expensive than a product that's pharmaceutical and that's available. They can both still be bioidentical. Okay. So it doesn't compromise. If you want bioidentical, you're not compromising that want by choosing a product that's over the counter that you can get from any kind of local pharmacy. Now, we can also adjust the dosing with a lot of these pharmaceutical products. A lot of times, I've had patients, cut patches or, do other dosing strategies that align with their needs. And so there is a little bit of customization available, a lot more than you think. So when it comes to creams, I'm not a big fan of the compounded creams because of all of the things that I mentioned. So I want you to know off the top, when I'm talking about bioidentical hormones, I am actually referring to the pharmaceutical ones. I'm referring to the ones that are available over the counter. And so head-to-head bioidentical, we are looking at the bioidentical versus the synthetic, pharmaceutical versus pharmaceutical, okay? So when we look at the estrogen selection, okay, a lot of patients are like, oh, I want bioidentical because it's safer. And the reality is when we look at estrogen, the safety comes down to the route of delivery, not whether it's synthetic or bioidentical, okay? And I'll explain a little bit further. When we look at the route of delivery, so when we're choosing our estrogen, we can choose a number of options. We can choose oral estrogen, which largely the oral estrogens are synthetic, like ethinyl estradiol. And this was designed for oral use. Or we can do a patch or a gel is kind of most commonly the preparation. Now, the way that we do estrogen has changed over the years because what we found is those synthetic estrogens, we used to give estrogen orally, and that was a synthetic estrogen. And the risks of that, not because it was synthetic, but because it was oral, is that it would have to go through the liver. And when we have that first pass effect through the liver, that actually drives up clotting factors and it increases, your sex hormone binding globulin, which if you are struggling with low sex drive, you don't want increased sex hormone binding globulin because that's going to bind a lot of your testosterone and make less of it available. And so there were some cons to being on oral estrogen, mainly the clotting and the cardiovascular risk was kind of the big things that drove companies and research to look at what topical estrogen could do. And what they found is that the synthetic estrogen wasn't absorbed through the skin in a very predictable or controllable way. And so by using the bioidentical or the body identical estrogen, we were able to have a more stable, consistent absorption through the skin of this hormone. So estradiol, being a natural body identical hormone, is lipophilic. And so it's going to absorb a lot better through the skin and it's going to be more stable in tissue. So from a hormone replacement therapy perspective, it was easier to deliver when we look at patches and gels. And then we avoid that first pass metabolism because it's not going through the liver, right? So we avoid and we bypass a lot of that cardiovascular and clotting risk when we use a topical estrogen. And like I said, that's mainly because of the way that we're delivering it, not because it's inherently bioidentical, right? We just know that a synthetic estrogen isn't very consistently absorbed in the ways that we'd like to deliver it to reduce risk, right? So a lot of times when we look at risk, we're looking at head-to-head synthetic versus bioidentical, but we also have to acknowledge the fact that synthetic is largely oral, right? Now, we know that this is kind of why your modern HRT favors that transdermal estrogen. And so, again, we have more stable dosing, fewer metabolic effects, and better alignment with physiologic hormone replacement. Okay. So when we're looking at the estrogen selection, typically the transdermal options that are found at your local pharmacy are going to look like a patch, and the patches have been largely backordered for a long period of time. But we have a patch as an option, we have a gel as an option. There is, my preference is going with Divigel or Estradot or Climera. There's also an Astellas patch that we can discuss in our session tomorrow, but my preference is going with something that has a dose that really can't be altered. And what I mean by that is when we start dealing with gels and creams that are in a pump and we say, do a pump and a half, I find that the dosing is a lot more or a lot less stable when we do it that way. And so when I'm talking to patients through this dosing, I do have a preference for Divigel if we're using a gel, because you can empty the full amount onto your arm or onto your thigh, and then you can rub it in, and you're not going to lose a lot of that dose potentially in the application process. So we do the estrogen. Like I said, we're typically going to use a bioidentical estrogen. Even your medical doctor will be using likely a bioidentical estrogen because of the way that the delivery is. So going to a more expensive prescription that is compounded at a pharmacy is not necessary, less consistent, more expensive, less safe. And so I think it's really important to understand that. I think a lot of the patients I see are so fed up. I saw a patient yesterday, and I always start when I'm working with the gynecologist office and we're talking about HRT. Largely, we're focused on menopause and HRT conversations. And one of the questions I start with every patient is I say, what do you hope to get out of this conversation today? Because what they're doing is they're meeting with me, the naturopathic doctor, and they're also meeting with the wonderful gynecologist that I work with. And we really work together in creating their treatment plan. And yesterday I had a patient say, honestly, my expectations are really low. And it's not because of you, but it's truly because I've been so dismissed for the last, whatever amount of years that I don't expect much from anyone. And I've been struggling and suffering. And so I think what happens a lot of times is patients go in to whoever their primary care provider is, and they say, here's what I'm struggling with. And the doctor either dismisses them or gives them a treatment option that is like subpar, or tells them that they're fine, or tells them that they need to wait for whatever reason. They feel frustrated, they feel dismissed. So then they go the completely other route. They go see a naturopathic doctor. They're like, I just want to do it natural, and I just want to do it different because conventional care is not helping me. And I think one of my biggest goals is to get people to understand that conventionally we can create a treatment plan from using hormone replacement therapy that is regulated, that is standardized, and that is not going to cost you an arm and a leg, that we don't need to be testing your hormones. If you are over the age of 45, we're not testing your hormones. There are people that there is nuance to that. I say this statement, but there's always nuance. There's always that one-off. There's always the person that needs the different thing. But ultimately, we are not testing your hormones. That doesn't give us any information. And research actually tells us, and this is actually one of the most frustrating things about perimenopause and menopause, is research tells us that your FSH, which is one of the markers that your doctor is going to run to see if you deserve treatment with HRT, right? Like, I say that very jokingly and sarcastically, because that is not a marker. There's not one test that identifies whether perimenopause is going on or where you're at, right? We identify where you're at by looking at how long it's been since you've had a period, right? We can look at other markers, but ultimately we look at age and stage and we say you're in perimenopause. If we do blood work, what we might find is 1 month you're going to be disappointed because I'm going to look at your numbers and say, oh my gosh, it looks like you're fertile. And then the next month I'm going to say, oh my gosh, it looks like you're in menopause. It doesn't give us any information. There are certain phases of perimenopause where it's more likely that your FSH is going to be sustained and higher. So over like 25 sustained. But up until then, things are going wild and crazy and wonky, and your estrogen is going wild and crazy and wonky, and your estrogen can go, high because some months you actually have two episodes of ovulation, and that can also worsen your symptoms, and that can also cause erratic bleeding. But because of that estrogen that's just like going crazy, that can suppress your FSH the next time we run it. And so we could actually look at your FSH and say, wow, you're fertile. But really, we didn't look at the whole process and the whole picture to make that determination. So what I'm saying is we have to take a step back. We have to understand that, all of these changes can happen and can be identified without doing a specific test. Do we need to rule out everything else? Yes, we do. Yes, we do. I saw a patient with anxiety the other day, crippling anxiety, which, by the way, is a very common symptom in perimenopause. In tomorrow's session, we're going to talk about the impacts of HRT and the things that it can do. But because the topic is so large, we're not talking about all the things we could do and all the symptoms in perimenopause. I think that should be reserved for other sessions. And I think that that's an opportunity for us to have some deeper conversations. But anxiety is one of the symptoms we see in perimenopause. We see changes in mood. We see quicker to snap. We see rage. We see crying. Like you feel like you're crying at the drop of the hat and you were never crying before. Like symptoms like that happen very commonly in perimenopause. And so we're talking through that. And yes, hormones create that. And yes, this is something that we need to be looking at and dealing with respect to hormones, especially if you're like 48 and you have crippling anxiety. HRT is probably a good idea. But ultimately, we can't ignore the fact that your thyroid needs to be looked at. Low iron can cause massive anxiety and heart palpitations and poor sleep. Like you name it. I think iron is one of the things that is most often ignored. Is people are so iron deficient and they're like, yeah, I'm in perimenopause and I have all these symptoms. And yes, we could do HRT and that's part of the plan there, but tackling the iron is like priority 1, 2, 3, 4 there, right? We need to look at vitamin D. We need to look at insulin. We need to look at inflammation. If you've seen me before, you've heard me talk before, like the insulin glucose challenge is the hill that I'm going to die on for testing, because I want you to understand what your insulin's doing, not fasted. I want to see what happens after you consume carbohydrates, right? Because in our day-to-day, we're not just hanging out fasted all day. So that's, I digress. But when we look at the selection of our hormones, we don't necessarily have to choose a bioidentical. Bioidentical is not necessarily better when it comes to estrogen. Okay. So that was a conversation about estrogen selection. We're selecting it based on risk and route of delivery. So like I said, my preference is transdermal, because when we look at research on transdermal, we see that it reduces clot risk and it reduces strokes and it reduces the things that we're scared about when it comes to oral estrogen, right? And it just happens to be that the route of delivery for transdermal estrogen is better done with bioidentical. So pretty much most of the HRT you'll find that is transdermal is likely going to be bioidentical. Okay. Doesn't have to be a compounded cream. That's my point. Then we move on to the progesterone selection. So with progesterone, we're giving progesterone again because ultimately we're protecting the uterus. Okay, we're protecting the uterus from estrogen being unopposed. Progesterone does have its own benefits, but if we kind of boil it down to, what we're looking to achieve, really, like that is the major protection, that is the major risk. And so when we look at synthetic progestins, we have a number of different options, but these can provide more potent and consistent endometrial suppression. So when we're making our progesterone selection, we have to look at the whole picture. So the typical ways we deliver progesterone can be bioidentical and can be synthetic. Bioidentical is typically given in oral micronized progesterone. The oral, if you've ever taken progesterone, it's like the big ball. It's 100 milligrams per tab. And one of the reasons for that is because bioidentical progesterone is not well delivered in any other capacity than oral. So transdermal progesterone, if we take a bioidentical progesterone and we put it on the skin, it does not achieve a reliably therapeutic level enough to protect the endometrium. So this is actually unsuitable to do the topical progesterone as a cream in order to protect your uterus. Okay? So when we look at bioidentical preparations, we can do an estrogen cream, a gel, a patch. I would prefer if it's not compounded. But oftentimes when we look at progesterone, it also is available in creams. We can get those compounded at a pharmacy. However, the same rules apply, like I said, with estrogen. Less consistent, safety issues. I find inconsistent dosing and all the things. We have risks of contamination, but also it's more important. So if you're like, but I've done a bioidentical cream from my naturopath and I loved it, no problem. But if you're on estrogen, it's not a reliable way to protect the uterus. So I kind of weigh my pros and cons. If someone is only on a bioidentical progesterone cream and they're not on estrogen, my first question is, what's the cost, right? Because again, when we compound a prescription, we're worried about the cost. My second question is it working for you? If it's working for you and you're achieving the outcomes you're looking to achieve with that progesterone cream and you're not on estrogen, I'm usually okay with it. I'm usually like, okay, well, like, let's let it go and let's see how you do. Because some people just don't really tolerate progesterone well. However, if you are on an estrogen, our first priority is that we protect the uterus from unopposed estrogen. And so that bioidentical compounded progesterone cream is not good enough in that scenario. So I have an inclination to not prescribe. Like, there are very, very few patients I have on a topical progesterone by a compounded cream. And that's for very specific reasons. A lot of times that is patient preference. A lot of times that's something that they've specifically requested due to a number of things. And they're not on estrogen because it doesn't protect the uterus reliably. So the way that we protect the uterus is by oral micronized progesterone. There is some research on vaginal. So some of my patients do not tolerate the oral progesterone. It makes them bloated. It makes them constipated. And vaginal is a viable route. Long term, I prefer if my patients can take it oral. But we actually do have some research that shows that when we do the vaginal progesterone, this does offer an alternative route because we're bypassing the liver metabolism. We are putting it locally in the vagina, which leads to local higher endometrial exposure with lower systemic levels. However, as it pertains to menopause care, this is not the standard of care. Okay. There's no long-term data. We do have to look at patient preference and consideration, but just looking at, overall, what are your goals? We do have to individualize this, but just noting that this is an option, but it is not the widely accepted option. So we have to make sure that we're talking through all of these options here. Coming back to progesterone, we have bioidentical, which is typically, like I said, oral micronized progesterone. I talked about why the creams are not the ideal situation here. The compounded creams, we're either doing oral or we can do it vaginal in certain circumstances, or we can do a synthetic progestin. Synthetic progestin is available either as an IUD. Not a lot of people know that you can actually do the progesterone IUD, the Mirena, as part of HRT. Now, this is specifically advantageous for people who are looking to really influence bleeding. So if the biggest concern, if a patient sees me and they say, my bleeding is out of control, I'm bleeding every 2 weeks, they're like 48, 49, I'm bleeding every 2 weeks, it's heavy, they're iron deficient, it's really impacting my life in a negative way, I'm spotting throughout the month, the IUD would be my choice on how they go about using their progestin, because this is going to be very predictable in stopping the bleed. What we know about synthetic progestins, again, we can deliver it as an IUD or we can deliver it as a patch. There's a patch called Astalis, which has estrogen, bioidentical, and synthetic progestin. And those can more reliably reduce and stop bleeding. We do know the IUD does have a little bit of stronger evidence for stopping the bleeding. So if bleeding is a big problem, I'm like IUD plus estrogen. The benefit of the IUD is it also doubles as contraception. And so if you're in that window where you're like, okay, could get pregnant, I'm 48, not, a high chance, but I could, and bleeding's an issue, maybe we do the IUD and we do a Divigel estrogen gel, right? the IUD being a synthetic progestin delivery, and the Divigel being a bioidentical estrogen delivery, right? So again, it's all about having this individualized conversation. And we're going to go into this a lot more in Not Your Mom's HRT. I am just diving into this one specific topic right now because I thought it would be useful. And these are conversations I have every single day. But we know with oral micronized progesterone, there's a little bit less. So the bioidentical oral progesterone, there's a little bit less predictable bleeding control. And I always say to patients, like at this time in life, in perimenopause and menopause, the goal is not to regulate your period. We're not looking to regulate your hormones. A lot of patients will come to me and say, my hormones are all over the map. I need to understand if my hormones are all over the map. I'm like, no, they are. Like objectively, they are all over the map. Our goal is not to identify whether that's true. I know it's true. You know it's true. You feel it, right? The goal is not to identify whether or not your hormones are all over the map at the age of 48 or 49 or even 43 or 44. The goal is to determine how do we look at what else is going on and how do we map out a plan that makes sense for your needs, right? So instead of saying, my hormones are all over the map, let's balance them, we have to say, okay, we know your hormones are going to be all over the map. Is bleeding a concern? Should we stop it? Right? How can we manage the rest of your symptoms? What other testing do we need to do to understand the full picture? How's your thyroid? How's your iron? How's your B12? Because not everything is hormones. How's your insulin, right? Now, we know that the reason why, again, like I said, the bioidentical progesterone isn't well absorbed through the skin. And so that is why we give it orally. So when we're looking at progestins versus progesterone, I look at a few things. Is bleeding a concern? IUD or Astellas? Astellas is going to be less predictable, but it's a patch. Some people just don't like the idea of getting the IUD, which is totally fine. IUD or Astellas. If sleep is an issue, I will give oral micronized progesterone. And the reason for that is because oral micronized progesterone goes through and is, processed by the liver, which inherently creates compounds that allow it to act on GABA receptors and create more of like a calming situation that helps you sleep. So if sleep is the biggest issue, then my progesterone selection is more likely to be oral micronized bioidentical progesterone as the option best suited for you, right? And so in those conversations, that is what we're talking about, is which selection is best for you. Should you get the IUD? Should you get oral progesterone? What sort of estrogen route are you going with? Right? We know that Astellas is the patch, combo patch, bioidentical estrogen and synthetic progestin. Again, it's easier. Some people like it because it's your estrogen and progesterone in one. It's not going to help your sleep. So again, if sleep is a big issue, there's some evidence that shows estrogen alone can help with sleep architecture. And so maybe we go that route because we're like, don't like bleeding, don't, want to bleed less, don't want the IUD, but also, sleep's an issue, but also want one thing. You could choose that. And there's nothing wrong with choosing the combination of one synthetic hormone and one bioidentical hormone in a topical nature. So that's kind of the once over of bioidentical versus synthetic hormones. Again, this is all about an individualized conversation, but knowing the risks and knowing the trade-offs. Now, when we look at the breast cancer risk, a lot of people are shocked when I tell them, and this is actually something I'm going into in quite a bit of depth in our chat tomorrow at 7 p.m. So if you haven't got your tickets, laurapfeiffer.com/events, Not Your Mom's HRT, virtual or in person, you're getting the recording if you don't come live. But if you come live, we have an extended, or if you come in person, we have an extended Q&A period. But we're talking about progesterone and the nuance because the research is nuanced. What I will say, just for the purposes of this live, is that a lot of people think that the estrogen is the driver of the breast cancer risk as it pertains to hormone replacement therapy. And that is actually false. The progesterone is actually the driver of the breast cancer risk. The reason why we know this is because when we looked at research, they looked at people with a uterus and people without. With a uterus, as you've been hearing me speaking, needs progesterone. Without a uterus, doesn't. When they looked at the research long term, they found that people with a uterus were on estrogen and progesterone had a higher risk of breast cancer. People on estrogen alone actually had a reduced risk of breast cancer. What's interesting though, if we come to 2026 and we look at some of the observational data that continues to show up in our literature present day, we're repeatedly finding a lower breast cancer signal for estrogen plus bioidentical progesterone compared with estrogen and synthetic progestin. We still do see a little bit of an increased risk and an increased signal for breast cancer in both bioidentical. So it's not risk-free, as well as synthetic. But we're seeing a little bit lower of a signal in the bioidentical progesterone, and we're seeing that signal or that risk increase later than we do with the synthetic. We're going to go into a lot of the data as it pertains to breast cancer, because this is one of the biggest risks people are concerned with. For clot risk, the biggest driver is still the estrogen, and it is still the route of administration. We know that transdermal estrogen is more favorable than oral estrogen overall. We also know that the micronized bioidentical progesterone does appear to be largely neutral from a clotting standpoint, and certain progestins might be less favorable. Now, the evidence is not clear enough to say like progesterone's, synthetic progesterone's also increasing clot risk, but this is just something to consider, right? There's a lot of things to consider, and ultimately when it comes down to it, nothing comes without risk. Everything we do is a risk benefit. We have to think about all of the things that I've discussed, but I just wanted to take today and go over, bioidentical versus synthetic. Is one better than the other? Hopefully I've shown you the differences there. I'll post this for anyone who came late and wants to watch the replay. For anyone who wants to come to Not Your Mom's HRT, it is tomorrow at 7 p.m. You can get the Zoom link, or you can come in person. It is in Barrie in the South End. If you're not in Barrie, come virtual via Zoom. Everyone gets the recording. It's going to be a really good time, and I look forward to seeing you there. Again, it's laurapfeiffer.com/events. You can head to the link in my bio to register, or you can go to the link that I have there. So I hope everybody has a great day. Like I said, I'll repost this for anyone who missed it or came late, and we will see you tomorrow at the event. Bye.